He's a professor and chairman at Hirosaki University and also the vice principal of University Hospital. And he has achieved many research, and he has many awards that I'm not going to present right now because of the time limit. Please, Professor Ohyama, please proceed.
Okay, thank you very much, Professor Sungil Kim, and I also very appreciate this good opportunity to give my talk here in Taipei. So before my scientific talk, I'd like to introduce my university. Hirosaki University is located at Aomori Prefecture, and there are some several direct flights from Asian big cities to Aomori Airport. And our place is famous for its good product of Fuji apple, and also in springtime we can enjoy a very nice cherry blossom festival in a very old castle. And big size tuna is swimming around Aomori area. So this is one of the biggest New Year news. Big tuna caught around Aomori was sold at $3 million New Year first auction. So please come to our place and enjoy good tuna and good apples. Okay, so let's move on my scientific talk. I think everybody agree that standard treatment for the patient with muscle-invasive bladder cancer is radical cystectomy. However, generally speaking, the overall survival, 5-year overall survival after radical cystectomy is around 50%, and this is not enough. So what should be done for better oncological outcome? I think one of the best promising strategy candidate is extended lymph node dissection. And Professor Dr. Ulf Studer, he's a former professor of University of Bern. He published several reports concerning his extended lymph node dissection. However, the optimal extent of lymph node dissection is not clear. Very recently, a German group carried out a very nice RCT comparing extended versus limited lymph node dissection for the patients with bladder cancer. So, but unfortunately, there are no statistically significant difference between extended and limited lymph node dissection in terms of overall survival, nor progression-free survival, and cancer-specific survival as well. So how about neoadjuvant chemotherapy? This neoadjuvant chemotherapy has many good evidence for survival benefit. As we were known, cisplatin-based chemotherapy such as MVAC, MCV, or CM exactly prolong the survival for the patient with muscle-invasive bladder cancer. So the guidelines always strongly recommend cisplatin-based neoadjuvant chemotherapy for muscle-invasive bladder cancer patients. And we also confirmed the survival benefit of neoadjuvant chemotherapy, cisplatin-based neoadjuvant chemotherapy for muscle-invasive bladder cancer patient. Our cohort included more than 500 patients with MIBC, and this retrospective study successfully demonstrated the survival benefit, overall survival benefit with neoadjuvant chemotherapy comparing the cystectomy alone. So the other important issue is the timing of cystectomy, because muscle-invasive bladder cancer is very aggressive. So if the timing is delayed, the oncology outcome became worse and worse. So this is also a very famous paper based on SEER database, and the mortality increases if the radical cystectomy is delayed more than 12 weeks, 3 months, or 90 days. So guidelines strongly recommend not to delay cystectomy more than 3 months. The final big issue is the method of operation. Open radical cystectomy or robotic assisted cystectomy, which is better? So as we know well, there are several advantages of RARC, robotic assisted radical cystectomy, against open cystectomy, such as hospital stay and blood loss and complication rate. However, the oncological outcome benefit with RARC is still unknown. But fortunately, very recently, this is last year's paper, robot-assisted radical cystectomy versus open radical cystectomy in patients with bladder cancer. This is named RAZOR trial. This RAZOR trial successfully demonstrated non-inferiority of robotic-assisted cystectomy against open cystectomy in terms of progression-free survival. Although this is not big sample trial, but I think from now on, the robotic cystectomy may be a standard of care of muscle-invasive bladder cancer. So, taking all these evidence together, I developed one contemporary strategy for muscle-invasive bladder cancer. Neoadjuvant chemotherapy is very important. It should be done first, and followed by RARC, and lymph node dissection area should be standard area, and hopefully the urinary diversion should be done intracorporeally. So this is the neoadjuvant schedule of the contemporary strategy. Gemcitabine plus cisplatin or gemcitabine plus carboplatin neoadjuvant chemotherapy should be done until day 42. 2 courses of neoadjuvant chemotherapy. We think the 2 courses of neoadjuvant chemotherapy will be enough to control the invasiveness. And after the termination of 2 courses of neoadjuvant chemotherapy, radical cystectomy using robotic surgery should be done within 30 days. So if we keep this rule, we can guarantee the timing, 90 days rule successfully. So 2 years ago, we already published our initial data, which are describing the feasibility and effectiveness of RARC with the neoadjuvant setting. And this is my list of patients who are treated with radical robotic cystectomy in our university. So all of these patients are muscle invasive, and all of them received neoadjuvant chemotherapy. And for the first 4 cases, we used extracorporeal approach for urinary diversion. And after, from the number 7 patient, we started intracorporeal neobladder procedure. And we accumulated enough patient, so this procedure is very stable. And now we can apply this new strategy even for prostate cancer patients who were previously treated with IMRT. Even in this very high-risk patient can be treated with new contemporary treatment strategy. And pathologically speaking, we achieved 34.4% of PT0. And we have no experience with peritoneal dissemination due to, I think, our 2 courses of neoadjuvant chemotherapy is enough to avoid peritoneal dissemination. And our series is still small, and follow-up period is still very short, but overall survival was 5-year overall survival is 81.2% for now. 81.2%. So I'd like to introduce my patient. He's a very ambitious 49 gentleman, and his tumor is T3N0M0 UC, grade 3 UC, and this is not good for him, but this tumor is very aggressive INF-C pattern. But he is very ambitious, so he required many very difficult thing for me. He wanted to cure his cancer completely, and he didn't want to have a stoma. So he wanted to void normally, and furthermore, he consisted on playing golf, and he's very active. So his IIEF5 was 25 point. He's a complete gentleman. So after I thought many times, I offer this strategy. Neoadjuvant chemotherapy with gemcitabine and cisplatin, and nerve-sparing RARC, followed by intracorporeal neobladder. And this is his nerve-sparing robotic-assisted radical cystectomy. His bladder is here, protected here, and because we are very familiar with sorry, okay. So some voices included. So successfully, his prostate and bladder is removed. Again. Oh, sorry. Oh, okay. Oh, very unstable. Okay. And the total operation time was 6 hours and 13 minutes, and blood loss was 100 ml. And fortunately, pathological status is PT0. And 6 months later, this is a voiding profile for him. It's very nice and without residual urine. And the Qmax was 39 ml per minute. His urinary stream was very strong. And at 1 year after the cystectomy, his IIA5 sexual function was rapidly improved, and he enjoyed playing golf and without incontinence. So he is now very satisfied with a post-operative course. So we urologists have a long history of urinary diversion from ureteral sigmoidoscopy, stomy, aerial conduit, continent reservoir such as cock, and neobladder developed by Dr. Studer and Hartmann, and laparoscopic radical cystectomy and intercorporeal diversion was developed by Dr. Gale. And most recently, RARC followed by intercorporeal urinary diversion is available. So this is the history of urinary diversion of our hospital, and we have good experience with the ideal neobladder. And this type of we developed our original U configuration urinary neobladder. So I developed intracorporeal version for our original U-shaped urinary neobladder. So only 40 centimeter of ideal loop is enough to make our neobladder, and this isolated ideal loop should be first connected to a pelvic floor, and then detuberalization and suture between the two plates, and ureter is connected to this ideal bladder and close the ideal pouch. It's a very simple procedure. I'm going to show you the video clip. This ideal loop has already isolated, and first this ideal loop should be placed to fixed to the ideal floor, pelvic floor. And after detuberalization, the urethral stem and ideal plate is sutured by a running suture like this. And yeah, next step is the suture to form inverted ideal plate. And then the left ureter is connected to ideal plate. And ureteral stent is inserted through urethral orifice. And just we are just about closing the ideal pouch. Because the ideal this shape is very simple, and the procedure is very easy to perform. Leak test is okay. So when we compare intracorporeal approach and extracorporeal approach, because our procedure, technique of intracorporeal neobladder is rapidly improving, the total time is very comparable. And blood loss, renal dysfunction, and surgical site infection, the ileus, when we look at this difference, I prefer intracorporeal diversion to extracorporeal diversion. So in conclusion, our neoadjuvant chemotherapy and RARC strategy for muscle-invasive bladder cancer is very feasible, and this strategy may be very promising. Thank you very much for attention.
Thank you, Professor Ohyama, for your